Yeah, good morning, you all, sir. With huge thanks to you for all the nice words and to the organizers. I think this topic has been kept that the EDKA a click must know in modern diabetic care. So I think as a mission, I am propagating this message to the all the our audience or to the physicians and why it has become so important these days. This is what we are going to discuss. If you go in the back, it was first described this the EDK, that is the euglycemic diabetic ketoacidosis in 1973, and later on, as you see, that there is evidence of changing trend. That is important. The changing trend from these early reports of EDK, as the use of new molecule came, this SGL2 inhibitors. So in the era of SGL2 inhibitors, it has become very important to understand about the EDK and why I am going to tell you. I think this was a landmark article which was published in the Diabetes Care in 2015 that the 20 clinical cases requiring hospitalization captured between March 2013 and June 2014 and in the FDA adverse event reporting system database, and that it was in focus again. And today, if you see, approximately 2.6 to 3.2% of DK admissions, whatever DK admissions is happening in these hospitals, this much is from the euglycemic. And you are well aware that SGL2 inhibitors increase the risk and overall incidence of DK from only SGL2 inhibitors use is approximately 0.1%. So I think this is an important data. So now if I ask a question, which one is more dangerous, the diabetic ketoacidosis itself or EDK? The typical DK mortality, you are aware that it is around 0.65% to 3.3%. And given the diagnostic dilemma of normoglycemia or lower than expected blood glucose levels, EDK portends worse outcome if you compare with the classic DK. So this is the first point to make you aware that this is a dangerous condition. Although data is less, but the maternal EDK can increase the rate of fetal demise up to 9% and increases the maternal mortality. This is the data. So classic diabetic ketoacidosis and the euglycemic variant. So let us discuss something old, something new. Let us see this case. This is important. A 52 years old, type 2 diabetes for 7 years, taking some clinic from the camp. This is a case from the Dr. Pratap Jethwani. He went to with this medicine on the Pioge, metformin, Dapaten and metformin and rosuvastatin. This was the patient, and he went to the Vaishno Devi, and there was less calorie intake there, and there was lots of exercise due to the walking or whatever it may be. So what happened? He developed profuse vomiting, nausea, unusual symptoms, so much such that he had to give admitted at this Srinagar. And you can see here what was found. The sugar was 235, the blood pH 7, bicarbonate you can see it was less, and urine for ketones were positive. So what they did, they diagnosed this case as with this DAPA background and with this history, they diagnosed it as the euglycemic ketoacidosis. So this is how the patients can present to you. Totally non-classical from the DKA. So if you ask me, why this case of the euglycemic decay, was it due to the SGL2 inhibitors? What you are going to do next? Let us see this. So this EDK is clinical syndrome occurring both in type 1 and type 2, remember. And if you need three things to diagnose, one is the euglycemia, that is blood glucose should be less than 250, number one. Metabolic acidosis should be there, that is you do by the pH less than 7.3 and bicarbonate less than 18 and ketonemia. And with this history, if you get in any SGLT inhibitors patient which presenting with such symptoms, you can diagnose this case. What happens in this case? The SGLT inhibitors promote mild ketogenesis due to increased free fatty acid availability and decreased insulin secretion. You are well known. And you can, if you see this paper, recent paper, this may be CANA, DAPA or EMPA, they all favor this comparator that rate of diabetic ketoacidosis with SGLT inhibitors. If you compare with the gliptins and sulfonylurea, this is definitely showing that this is the culprit. So whenever patients are having risk factors like patients on SGLT inhibitors with some infection, with some going to surgery, some fasting is there, has taken too much of alcohol, acute vascular events is there, some trauma and prolonged physical activity. Remember the prolonged physical activity which happened in that case when went to the Vaishno Devi barefooted. So this was the case. So I think this should be our patients should be aware that all these risk factors are very important. And potential high risk factors of euglycemic diabetic ketosis and their mechanisms, you can see, I told you about that. I'm not going in details on how it happens, but remember that when SGLT inhibitors patient is increases the lipid oxidation, so there is increased lipolysis and glucagon. Then there is increased mobilization of the free fatty acid and triglycerides. There is increase in the ketogenesis, increase in the beta hydroxybutyrate, that is worsened by decrease in the insulin because the insulin has been not taken some in patients, and carbohydrate intake if it is decreasing. Suppose in some situation where patient is totally stable, but due to some regions has not taken the proper food or carbohydrate, this could be a problem with increase of the ketones, inducing the nausea, decrease in calorie intake, volume depletion, and blood glucose mildly higher, so further decrease in insulin and rapid development of this UDK. So this is happens. This is how happens. So what is your difference? In the here you can see that there is less insulin B, glucose utilization is preserved, and euglycemic ketonemia occurring. So this is how this is happening. This is a very good one slide to understand that SGLT inhibitors decreasing the glucose level is decreasing, insulin level is decreased, glucagon is increasing, and ultimately increase in lipolysis, free fatty acid production, beta oxidation, ketone body production, and leading to euglycemic diabetic. There are lots of things there to understand. So simplifying this, the overall euglycemic diabetic ketoacidosis shares a similar pathophysiology with diabetic ketoacidosis. Remember, except for the unique circumstances of SGLT inhibitors induced glycosuria. दोनों एक ही चीज है, but here what we are getting the SGLT inhibitors induced glycosuria, and this mechanism of artificially lowers plasma glucose levels, thereby increasing the predisposition to the ketogenesis. So this is important. Now, how to diagnose it? I told you that remember that EDK is also a like DK, but lacks the classic hyperglycemia component. Remember. So in EDK, the blood glucose is generally less than 200. Most of cases you will get less than 200. Although some reports earlier they told the cutoff of less than 300, but today 250 is considered the most accepted definition. So if the blood sugar is less, you getting the arterial pH by less than 7.3, I told you, and anion gap is more than 10, you can diagnose this case. If you see the lab value, what is happening with the EDK and DK, see here. Only thing I find that in DK, it is the sugar value, glucose value that matters. Other list of the other things are almost you see is similar. Although they have also classified as some stages of 1, 2, 3, 4. I'm not going to. In type 1 diabetes also you get many cases. You are well aware that there has been put on the SGLT inhibitors in type 1 diabetes. One time it was also approved in the type 1 diabetes, but later it was, I think, in even the European Medical Agency banned it. So in that cases also it happens. So again, I will to summarize up to here that any time if the inappropriate reduction of insulin dosage or any factor that may increase insulin demand, such as a stress, a sick day, or alcohol intake, may induce hyperketonemia. Very important. And this is very, very important situation which can appear. So EDK is in fact easily detectable because reliable tools are currently available to monitor ketonuria. You can have in your clinic a ketometer by the Abbott, and you can just see that the ketonemia and should be recommended to use at any time. Some patients in such situations, sick age, stress, and patient or SGLT inhibitors, ideally should this ketone meter they can be kept in the clinic, and then can be even the patient can keep it. And if the patient of any SGLT inhibitors patient, and if he feels unwell any time, regardless of the ambient glucose levels, थोड़ा दिमाग में सोचिए कि this could be the EDK. So this is the second point I want to. So this is very educational element to our physicians that this point should be highlighted. Then you take the history, you will get the typical history of sign and symptoms, whether its onset can be more insidious compared with the hypoglycemic DKA, and they may present with deep rapid breathing, or there may be a fruity odor later on and tachycardia. That all the symptoms later on will just like DK that can happen. So I told you about how to diagnose this. I'm not going to detail it. Then in how to evaluate such cases. So what you are going to do? Initial evaluation of basic electrolytes, glucose, calcium, magnesium, creatinine, burns, serum and urine ketones, beta hydroxybutyric acid. Then this arterial and venous blood gas analysis. Sometimes if you have some issues that it could be, suppose patient is also taking metformin, and if you think it could be a lactic acidosis, so also you just go for measuring lactic acidosis, lactic acid, and accordingly lots of things are there. So these are the usual things which should be done in the ICU. Serum and urine ketone must be elevated to make the diagnosis of ADK. That is important. And lactic acid must be elevated, but should not occur entirely for the elevation in the anion gap. So that is also, you see the level of anion gap. Accordingly, potassium levels may vary, but great attention should be paid to the level before starting therapy, as total body potassium is usually depleted in such cases, and mild hypotonemia could be there. So I think this says you the major differences, how to differentiate between the DKA, euglycemic DKA, starvation ketoacidosis, and alcoholic ketoacidosis. These are all differentials, and you can have some idea how to do that. So this is a difference between the diabetic ketosis, and this is important again, that the endogenous insulin is not stimulable in the diabetic ketosis, but here you can stimulate it. And you have, if you are giving glucose, there is no benefit in the diabetic ketosis. But in the euglycemic, the benefit at the onset, and the renal glucose threshold is elevated above normal, but here in the euglycemic diabetic ketosis, it is lower than normal. And remember, the duration of ketosis under treatment, if you are treating such case, in diabetic ketoacidosis is usually up to 15 to 20 hours. It could be up to 60 hours from the last dose of sodium glucose, this is SGLT2 inhibitor. So this is very important, that this can prolong too much, 60 hours. So this is important. Then how to manage such cases? Remember, a very important thing, don't stop insulin. Sugar is less, but don't stop insulin. Insulin should be delivered at a fixed rate of intravenous infusion until the anion gap corrects and the patient can transition to oral intake. This is very important. And also second point, that dextrose infusion, preferably 10% water, is typically necessary in EDK to prevent the hypoglycemia. So these 2 points are very important. ये थोड़ा उल्टा लगता है, ये sugar कम है, why you are giving insulin, and why you are giving this dextrose, but this is the main treatment of the EDK. So this is very, very essential to such patient to diagnose and treats, and patient may need longer treatment of DK of the setting of SGLT inhibitors. So I think this is the more things when our RSSD recommends about the fluids and other things, these are all available. So I think then you blood glucose levels should be checked hourly, and sodium bicarbonate infusions are not indicated. Patients generally require ICU admissions for close hemodynamic and laboratory monitoring, and treatment with IV fluid resuscitation should continue until the anion gap closes and acidosis is resolved. So these are very, very important things. The differentials I told you. Prognosis. Most patients, if you treat properly, they will recover well, and this prompt recognition and treatment. Only thing problem happens when there is delayed diagnosis, which happening too much. And prognosis is worse for a small children and pregnant women. And death is rare in most of the EDK patients. That is important again. Death. So if you treat the way I told you, the death is usually rare. So in treatment of SGLT2 inhibitors induced DKA, a tendency towards euglycemia results in clinically relevant reduction in the amount of insulin given over the first 24 hours of treatment. It remains unclear whether the protracted duration of SGLT2 inhibitors DKA is a result of it. That is, I'm talking about if the patient has developed SGLT2 inhibitors and DKA, that is in DKA. So I think this chart again tells you the manage simply how to manage that. IV infusion at 1 to 2 units per hour. IV dextrose to maintain blood glucose between the 120 to 180. An advanced diet and give carbohydrate. This is important again. You start this giving the carbohydrate and treat the ketones and anion gap. And later when the anion gap diminishes, or then you can go for the transition to the subcutaneous insulin. So I think this is one single slide is important. Well, patient has developed this case developed this EDK. And this is suppose a case of atherosclerotic cardiovascular disease or some CKD is there. Are you going to restart it? That is again a very, very important question. There is no clear answer for that today. A blanket no may be medically and legally appropriate answer. Remember, blanket no, we say blanket no, but it should be noted that insulin is not discontinued even after serial episodes of DKA. The answer should be based on in-depth review of the risk-benefit ratio and discussion with the patient I described above. But I feel that after few months, 3 months, 6 months, with proper education, and suppose patient is going to do some Mahakumbh and some Ayodhya and walking, then patient can take care of that, stop the SGLT2 inhibitors, go for that, and then in such cases may be started, because what I am showing here again, that literature says is it can be restarted, but it is very difficult to tell you the exact thing. So clinical pulse, I already told you, if there is, you feel that patient has some sick days, patient going for unusual exertion, no carbohydrates are not available, stop SGLT2 inhibitors before that. I think and have mitigated by drinking and eating as tolerated without fear of hyperglycemia. उसको बोलिए तुम खाते रहो थोड़ा सा. So this you can do that. So these are the pulse. And I told you all about what must you should do in such cases. Remember that the euglycemic DKA present without ketonuria. पेशाब में, यूरिन में ketones नहीं मिल सकता है. And patient may have having the EDK if the patient is on SGLT2 inhibitors, and so send a butyrate level to estimate. That is again a very, very important. And this is the most common in the first 2 months of SGLT2 inhibitors. When you have started on your patient, the first 2, it has been found it is more important, but can happen at any time. So what are the pitfalls? Not giving enough insulin to reverse the ketosis due to concern about low blood glucose. जब पेशेंट आता है आईसीयू में, यू आर नॉट ट्रीटिंग दैट, पहला इंपॉर्टेंट गलती जो हम करते हैं कि यू आर नॉट गिविंग इनफ इंसुलिन, not giving enough dextrose to support the sufficient insulin dosing, and not titrating insulin for refractory acidosis caused by EDK. ये 3 भयानक गलती हम लोग करते हैं in the EDK. I will not go for this MCQ, I think, but this leaflet of the patient education, which I already told you, is important. So ending my talk now, the top points are that euglycemic diabetic ketosis is a potential pitfall for the emergency physician, number 1. This all I told you, that more importantly, renal glucose clearance is twice as large with EDK than with the DK, and it is the intensity of glycosuria, the height of hyperglycemia, that marks the difference between the two conditions, the DK and the EDK. And depending on the body size, glucular filtration rate, and degree of hyperglycemia, SGLT2-induced glucose loss can make up a substantial fraction of daily carbohydrate availability. So these are all things. Remember that this is a life-threatening emergency. need immediate evaluation and treatment. And remember that although the hyperglycemia with blood glucose level sometimes less than 200 can result in delayed diagnosis and treatment, which is happening. In most of cases, it is happening delayed diagnosis because you are not suspecting it. Patient को अच्छा नहीं लगता, not feeling unwell. Patient is sick, taking SGLT inhibitor, not going to think about this EDK. That is happening. So it might occur not so infrequently in individuals treated with SGLT inhibitors. So these are all points. Thank you very much. I think I have given my points. Thank you.